nowadays is going to be Dr. Margo Baker. Not that she's counting. She's getting her doctorate at Creighton University, which is where Dr. DeGredo got her doctorate as well. And she has made this wonderful binder for you guys about OT on a shoestring budget. And I would love it if you could just take a couple of minutes and tell me a little bit about yourself.
Okay, as she said, I'm an OTD student at Creighton, and setting up this lab was one of my assignments for my class. They call it a rotation at Creighton, but it's kind of like an internship. I practiced 36 years as an occupational therapist with only a central vision loss. However, a few years ago, I started losing my peripheral vision as well. So I thought, now what I'm going to do. I had been a clinical instructor for 25 years for OTR and OTA students, and I really enjoyed teaching in the trenches, so to speak. Of course, it's a little bit different. You know, I only had 1 or 2 max, and it was, you know, pretty much on, you know, direct supervision. And so this is a whole different experience for me. So I'm a little nervous, but anyway, so I hope it goes real well. The minute paper that she handed you is very important to me. Part of my grade is getting feedback from you guys. And they call it a minute paper because it's only supposed to take a minute to fill out. So if you want to fill it out as we go, or spend the last minute filling it out, that'd be great. Just leave it on your tables to pick it up, and I'll compile it. So be honest, you know, tell me what you liked, what you didn't like, and that'll help me figure out how to be a better teacher. So this class will be a little bit different than some of your other labs because of my visual impairment. I need a lot of chatter. I thought we could do a vote on how you want to ask questions or answer questions, either by raising the hand or just in a very orderly fashion. I think it's called self-regulated. Just state your name and say what your question or your answer is. Either will work for me. So do y'all have any ideas? What would y'all like to do?
Why don't you guys state your name and ask the question?
That way too I'd get a feeling for who belongs to which voice and which answers and which questions. I'm also kind of planned it to be a very hands-on, very active. I'm going to be asking for volunteers. I bought treats for volunteers. I'm going to be having some of you simulate diagnoses. I'm going to be presenting things that I created and try to get you to come up with ideas of what kind of patients would benefit from them. It's Friday, so I figured if I made it very active for you guys, maybe I could keep you awake. Okay. All right. If you will turn to your manuals, I think there's a PDF. I think it begins on page 3, and I think it goes to about page 12. And you don't have time to read it now, but I would love for y'all to read it later, because that's only one piece of information I found that pretty much says the same thing. And it kind of dictates why you will find yourself in the work setting dealing with what I call my least favorite part of being an occupational therapist, which is the business side. You know, I think most of us want to be occupational therapists because we love people, we want to help people, we want to, you know, facilitate. The United States spends more money on health care than any other country in the world. So you would think that since we spend so much money on health care, we would have less adult mortality. Yes? No? We don't. We have less infant mortality? No, we don't. There's several reasons that have been hypothesized why we spend so much money on healthcare versus other countries. One of them is physicians in the United States get a higher salary than any other physicians in the world. Being as I got my OT degree on a medical campus, and so I had a lot of friends that were medical students. I really don't blame them for wanting a good pay. I mean, they pretty much give up their lives to be physicians. I watched them going through school. And the second reason is pharmaceuticals. You can get the exact same drugs in Canada or Mexico for half the price that you pay in the United States. So that's the second reason. The third is research, which is good. I mean, one of the good things we have on our report card is we have higher success in treating cancer than any other country in the world. So that part's good. And the fourth thing is technology such as MRIs, CAT scans. We have a lot of that and we use a lot of it. So it's hypothesized, are we overusing these technological things? So because of all the public awareness, there's two things that kind of drive healthcare policy, and one is public awareness. As soon as the public finds out these are issues, they're kind of up in arms. You know, as soon as the press gets hold of it and the public is going, well, wait a minute, why is this going on? Why are we spending so much money? We're not living longer, and we don't have less infant mortality. You know, then the public starts demanding changes. And the other thing that drives healthcare policy is research. So basically what this sets up for us is, and it's not just us, right now the focus is on delivering the most cost-effective, beneficial treatments with the least amount of adverse side effects. So that's what healthcare policy is focused on now. And it's not just us. I just got through reading the American Heart Association findings, and they're actually doing studies on which diagnostic test can detect cardiovascular disease the earliest, that's the least invasive and least expensive. So this is something that all healthcare is dealing with right now, not just occupational therapists. But so that's just kind of the background information of why this is a focus for us right now. The second thing is corporations. Okay, so you go to work for a corporation. There have been a lot of cuts in Medicare, that kind of thing. So we deserve good salaries, don't we?
Yes.
As hard as we work, okay. So how the corporations adjust for that is, and this is a word you may not hear in your field work. When I was a CI, I tried to protect my students from hearing the P word until they actually got a job, because I wanted them to focus on their skills as an OT, their skills to evaluate, to treat, document, all that kind of stuff. But as soon as you get a job, you will hear the word productivity, I can guarantee it. And that's how a lot of the employers deal with everybody's scrutinizing how much we're spending, but yet they're also tracking. I know my last job in the skilled nursing facility, all of our documentation was computerized. And so they would see, the computer would have the evaluation status and the discharge status. So they were actually tracking our effectiveness. And, you know, we were very good. We had, I believe, a 74, 75% success rate of returning people back to their prior levels of function. But, you know, so it's going to be tracked. And so employers will push for higher productivity levels from us. Rather than cut our salaries, they just want us to be busier so that we're creating more revenue. My last job, I had a 90% productivity expectation. So you have to learn to just be time efficient. What we did a lot, we had a very strong interdisciplinary team, and we helped each other. We dovetailed. Let's spend the last 10 minutes of OT and the first 10 minutes of PT doing dynamic standing balance, which usually takes 2 people to be safe. You know, so you work around it. It's really cool. The third thing that affects spending money is the patients and their families. You know, some of them will be low income. Unfortunately, there's a lot of things we would like our patients to have that insurances or third-party reimbursers will not pay for. And that's one thing I want to draw your attention to, page 27. And this is what I'm hoping will help you guys when you start your field work. I'm assuming that since you're here, possibly you'd be doing them in San Diego, Orange County. What I did a lot of, is that not true? Or giggles?
They go everywhere.
What I did was, over the years, you know, since I did it for so long, I kind of learned where to look for places to help these people. Almost everywhere I worked, you could find, whether it's through churches or March of Dimes, or there were even some private places that would have what's called equipment closets. I found 2 in San Diego, one for adults, one for children. I found none in Orange County, which I guess they're too affluent. They don't need equipment closets. But basically what these people do is they take donations of wheelchairs, walkers, tub transfer benches, bedside commodes, and they disinfect them, clean them up, and they either give them away or they sell them at a very low cost. And you would not believe how many people I would have to send home 95 years old. Maybe they had a fractured hip and they were 50% weight bearing on their hip and they had to go home that way. There's no possible way to get into tub or shower 50% weight bearing without breaking precautions. So they really need a transfer bench, and they're about $140, and Medicare won't pay for them. So it was so cool to have these resources to give the families as far as the equipment closets. There's also a lot of companies. I found one in there. It's a nationwide one, and you just go on their website and you click in where you are, that will come and do home modifications, because you talk about expensive. Those home modifications to make wheelchair accessibility are really expensive. I know when I was working in Austin, Texas, the city of Austin had a government grant, and if you were below a certain income, they'd come in and do it all for free. So, there's so many resources out there, so it's finding them. So that's helpful to the patients and the families if you can be that kind of resource for them if they can't afford it. You may know that a patient would benefit from a certain type of equipment, but are they going to use it? It's wonderful that we have the skill and the knowledge to know what the patient needs, but will the patient want to use it? I've run into patients that for some reason using something like this, they're just like a stick, they don't want to be seen doing it. They'd rather just struggle along. They'd look at it and go, I'm not going to use that. So rather than buying a set of built-up utensils for $90, I always kept cylindrical foam. I could buy it by the bag with different diameters. I think this is 1/2 inch, and I think that works for almost everything. So this would give me, the chance to present it to the patient and go, I think this would really help you. Will you try it for one meal? I would always just say, just one meal, because I was hoping that if they realized how much it helped, then they might change their mind. But just please use it one meal if someone's asking. So I do it for that reason. The other reason is sometimes when I would be working with them, it would be something they needed at the time, but it wasn't necessarily something they were going to need long term. A lot of times I would get knee replacements, and their knee is so swollen and stiff and everything, they would need all the lower body dressing devices. But usually by the time they got ready for discharge, the swelling had gone down, the PTs had gotten their range of motion really good, and they didn't need them. I did keep hip kits there. The only thing I did not dispense for people to try were the sponges, because that's a sanitary issue. But the reachers and the dressing sticks and the shoe horns, I would temporarily give it to them. I'd have them practice, and by the time they were ready for discharge, if they actually needed them, what I worked out with my facility was we could buy things at a discount because we were a facility. And so I would buy the hip kit at the facility's cost, and then I would just ask the family members to pay that amount. And I had it worked out with the business office, and the family members, when they leave, would drop off a check. So it really helped these people get this equipment that they, maybe were strapped to get. So that's the second reason I try the temporary fix first, because why buy them expensive built-up utensils if by the time they go home, say maybe they had a mild stroke, or they have a fractured radius, so their hand is in a cast, so they always have that in the web space, so it's hard for them to do any kind of pinching. All those are temporary things that hopefully will get better. So I would do this, and then these, once you're done with it, you can pop them in a commercial dishwasher and it'll sanitize them. So they're reusable and they're cheap. I think a yard of this is like $6. And I used a lot of it. But anyway, so this is just I just used cylindrical foam to simulate a built-up utensil. And in some cases I would have the patients take the utensil out because sometimes the kitchen where I worked would lose them. I don't know where they went. So sometimes the patients would just be in charge of them, and when they brought their tray, they'd put them on themselves. So that's the first thing. The table, I believe, begins on 13, maybe? There's a table, the left side, there's a low-cost option, which is the Margaret Fix. And the right side is the formal medical supply. And then from page 16 to 26, I have photos of all the things that would be the expensive version of what I create. And the table allows you to see how much money is saved by doing some of the things that I'm recommending.
Margaret, it's Rachel. I was just curious, did you ever show your administrators at the nursing home how much money you were saving?
No, I didn't. In fact, what's funny, until you asked me to do this lab, I didn't realize how much money I was saving. I mean, I knew I was, but the other thing is too, I mean, even if you get the facility to pay for it, I know I myself, we had to submit a request to administration. Administration might take a week to get it back. Then we handed it to the tech who would order it. So, I mean, you could wait up to 3 weeks to get whatever it is the patient needs. And they need you to be working with them right away. Exactly. So these are just some really quick fix things too. I mean, even if your patient has tons of money and they don't mind buying the expensive stuff, this is something you can use in the meantime because it's a bureaucratic process getting things for the patients. But, so this was the first one, the cylindrical foam on a feeding utensil. Okay, the second one is the clock method. Since I was in a skilled nursing facility and most of my patients were 60, 65 or older, I had a lot of patients that had age-related macular degeneration. And the onset would be fairly quick. And they would probably come in for something else. But as I was doing the eval and assessing their abilities to do their ADLs or occupations, I would notice that vision was really hindering what they were doing, even sometimes feeding. So as the free version of how to deal with these patients, I created a little clock on a plate because that's, y'all please let me know if you can't hear or see anything. This is my first time. And I used tactile numbers too, so you can even feel them. And I used black and big so that if they had, some vision, they might even be able to, to see the numbers, which I can actually see. So this is how you train a patient to use the clock method for feeding. And basically what ideally happens is whoever serves them their tray says, your meat's at 12 o'clock, your potatoes are at 9 o'clock, your vegetables are at 6 o'clock. Your water, I would even tell them based on the clock method where their drinks were. So maybe your water is at 11 o'clock, your milk is at 2 o'clock. And this helps tremendously.
Question? This is Courtney. About your clock methods there, you said you have tactile cues there? Where are they located? Are they located on the edges or?
Yeah, it's the actual letters.
Oh, the actual?
Yeah, the outline of the letters you can feel.
Oh.
You can feel.
So they're actually not on the edges or anything like that?
No, it's just the letters themselves because they're adhesive.
Okay.
And I think they're vinyl. I think they were made out of vinyl. I went to Staples and got them. They were 2-inch, I think. Good question. Anything else? I have appendices A, which is page 28 and 29, and this would be a good handout if you want. So I talked to my supervisor, and they would have mandatory monthly meetings for all the staff. And I said, I need to do an in-service, I really do. And so they set me up to do an in-service. And so I asked for one of the CNA to volunteer and come up, and I had her sit at the table, and I blindfolded her, and I went, here's your lunch, and I walked off, and she goes, oh. Oh gosh. I said, exactly. So you have to do a lot of caregiver training as well. And I also trained the CNAs, please ask the patients if they need setup. Because the silverware would come wrapped. The milk cartons obviously would be sealed, and milk cartons are hard for everybody to open, I think. And so I would say, set the tray down, ask them if they need to be what's told what's on the tray. If they say no, ask them if they need setup. And I said, I guarantee you'll waste less time, because if you don't do that, they're gonna call you back. You know, so just do it right the first time. It actually saves you time. Find the bowl and find a utensil, and she would just hold it here and eat. And I want to demonstrate what it takes to have that ability. If you'll take the bowl with it. This with the right hand. Okay, spread your arms apart. Now close your eyes. Now find the bowl. Okay. What sensation did she use to do that? Appropriate. Who said proprioception? That's proprioception, and that's why it worked for her so well. You know, so it works really well for blind people. We know where our right and left hand are, and we're pretty good at getting them together. And all of us use it. I don't know of any place of employment that does not have paper clips. And the same thing, if it's going to be a temporary thing and they might get better. Now, the other good things about the paper clips that the zipper pulls don't do is they're so narrow, you can tuck them in under the flap of material. Where the zipper pulls, I would always see were the round ones, you know, so they're kind of like sticking out. So the patients were actually more inclined to use the paper clips because nobody could see them. And everybody has paper clips. So that's why that wedge is there. They don't want complete adduction. They don't want the arm all the way by the side. And, you know, the patients used to say, why do I have to do this? And I go, well, you know what's holding it in there? Super glue, basically. It's only an adhesive, and it has to set. And I've seen patients that don't follow their precautions, and they pay in the end. They usually end up with a lot of chronic pain, so I would tell them as well. You know, do you want this to hurt for just 6 weeks, or do you want this to hurt for the rest of your life? So I would have the family members coming to me and going, you know, it's all fine in the skilled nursing facility. She's got a hospital gown on, but what are we going to do when they go home? You know, how are you going to go out in public in a hospital gown? So this is just a t-shirt, and the seam has been taken out, and Velcro has been put in. And that way you put it on the, you go ahead and put it on the arm that's not involved, and then, and obviously the person probably needs some assistance with this. I don't think it's anything they could do on the own. And then the other person helping them just comes along and starts Velcroing it around the wedge. I usually, when I'd have a patient like this, I'd go, who in your family knows how to sew? Yeah. Bring them here. And I would tell them, you know, whatever size they wear, get a size larger, and take the seam out and sew Velcro in. A good friend of mine made this for me. It cost her $5. Now, there really is no such thing you can order, so I think I came up with something that didn't exist. But director of Rehab came to me one time and said, Margaret, the ladies are wanting to give back. You know, we're offering them this place to me, do their quilting. What can you think of them to do? And I said, walker bags. Because there's nothing worse than you go to get your patient for therapy and they got Kleenexes and a cell phone and they're trying to walk like this with a walker and you go, no. So they're so handy, and God, they made like 100 of them, all different colors. And so I would even let the patient pick theirs out. Women liked them better than men, but I even did have a few men that liked them. It allows them to, you know, keep their hands on the walker where they need to be. And I don't know, do y'all do any walker training in this program?
Yes.
Okay, good. Okay, I probably don't need to go over that. I could show you all the horrible things I've seen if you like. I went to go get a patient one time, and there wasn't very much room between the bed and the window. And she forgot her Kleenex, and her Kleenex was on the bedstand. So here she is, she's about to follow me out of the room. She goes, oh, I need my Kleenexes. So she goes like this, and she goes, I'm going, stop! Or I've seen them do this.
that's how you do it.
You know, or pulling up on them instead of pushing up and then grabbing the walker.
Yeah.
But anyway, okay. Another thing I would use my maintenance man for was I would get these people in with hip fractures. And, you know, I'd ask them how they fell. Well, did you have your walker with me? Yeah, I had my walker with me. Can you have your family member bring your walker in? It'd be a rollator, which is a nice walker. 0 brakes. Brakes broken. So I would use my maintenance man to fix the brakes on the rollators too, because I wasn't going to send them home with a walker with broken brakes.
And then PVC brake extension.
Okay. This is something I created, and I wasn't quite sure what size tips y'all had on this wheelchair because I've never seen it. I created a wheelchair extension, wheelchair brake extension with PVC pipe. I got 1/2 inch because that usually what works with the smaller round rubber tips. But y'all have the fan kind, and they can't even be removed. But so I guess if you were going to use something like this for wheelchair, gosh, you'd probably need 3/4 inch, maybe an inch. But these work really well. So can y'all come up with some diagnoses that you think would need a wheelchair brake extension?
Question, Julie.
Yeah.
I'm sorry, but do those go on the handle with the brake?
Yeah.
Actually,
Yeah, this one won't fit though because this particular chair y'all have has the fan rubber tip on it, so it won't slide over it. I wasn't sure what y'all
In
had.
most nursing homes, Joe, they have just kind of the little round ones, and they have commercially available
Right.
brake extensions. That,
They're $50.
Yeah, so they're expensive, and
Yeah.
half the time you can't find them, right? And so.
They lose them.
Yeah, they get lost all
They
the
lose
time.
them.
So who else might need those guys besides our chairs?
Hey, stroke patients. He needs a candy bar. What other diagnoses would they not be able to use one of their arms?
Say real loud.
What if they had a cast? Fractured radius. Yeah, fractured radiuses usually have the casts that come all the way up to here. So it would be hard for them to reach, you know, to do the break.
Do you buy the PVC pipe, or do you have to like buy it in bulk ahead of time?
Here's the good thing. If you want to order big things, like capital equipment or expensive things, you usually have to wait once a year, like every other month was what I had to do. But we had to pay cash. And that's what was cool about that, because it was immediately available. And we used to keep different sizes on hand. You buy them 10 feet at a time, and you can make about 5 pairs out of a 10-foot piece of PVC, and that'll cost you all of a whopping $2. The other things I would use them for, sometimes people that have decreased vision, they have trouble finding the brakes, but if you put those big white honking things on there, they can find those easy. I had a woman who had dementia, and she'd forget to lock her brakes. So I put the white ones on, and on the top of them, I had my technician write lock in red print. And so that was the visual prompt she needed to lock her brakes. That's all she needed, and it worked really, really, really well. You can buy commercial brake extensions that actually have the word lock on them. This also works really well for patients with casts on their legs. It'll be a tight fit. Of course, you have to train nursing. They go, how the heck do we get that off, and how the heck do we get it back on? But it works like a charm. There's no way their legs could fall off the legs. What do you think? And if they're elevating leg rests, sometimes I'll put a pillow over it, and they are comfy as a bucket of rug.
That's a great idea.
They love it, and you know, any hospital, any nursing home is going to have laundry. So I used to use linens a lot. Put the clothespins on the edge of the coffee can. I want to make it more difficult, I make them pick it up. And usually taking them off is easier than putting them on, so sometimes if they have trouble with this, I'll put them on for them and have them take them off. So there's all different ways you can grade it too. And the cool thing was is if the patient wanted to stay in their room, I grabbed my mirror, which I'll go over that later, and my coffee can, and I had all kinds of stuff to do with them. Okay, now you take them off and put them inside the can. Got the napkin? The rubber. Pretty easy, right? Now you're going to be a stroke. This one. I'll let you put it on. Okay. Try to pick up some things. So now you know how a stroke patient would feel. Now, one thing you could do to make it easier, is it easier to grab it if I just hand it to you? Okay. So that's how you could start them out, is handing it to them. Now, I have patients that struggle so much, they get real resourceful, they pull it to the edge of the table and pick it up that way. So I found that if you let patients struggle long enough, they'll come up with an option. What I did with the back of our mirror was I took strips of Velcro and I did 1, 2, 3 levels. So people in wheelchairs could usually reach the bottom 2 and people standing could usually reach the top 2. And we all got together and just brought objects from home like plastic spoons, wooden blocks, coins. Someone brought a 9-volt battery. And we put Velcro on them and they had to take them off, which was a little bit of resistance. So usually I'd have them start out low, take them off, and then try to reach higher. So, I mean, for the price, since I had the mirror already, and just the price of the Velcro, and everybody donating their objects, it worked really well. And it was very mobile. So again, that's what I'd go to, they'd see me going down the hall with my coffee can in my mirror. But the other thing I did was, finger ladders are expensive, and I would use finger ladders a lot with stroke recovery, with humeral fracture recovery. It's a good way to do active assistive where they really can see that they're doing it all by themselves. If you have them under the elbow or whatever and you're assisting, a lot of times they go, well, you're doing all the work. But with the finger ladder, so what I did was I did a strip vertically on each side. That way, whichever arm you're working with, if it was the right arm, I'd have the finger ladder here and them sitting here. And if it was their left arm, I'd have the finger ladder here and I'd have them sitting here. I always guarded because sometimes they get real weak and they'll just, and that hurts if it's a shoulder fracture. So I would always have my hand hovering about an inch below their elbow so that I could rescue them if they slipped. One of the PT assistants, her husband had his own woodworking shop. And so he got, I got so many people to do things free for me. So he got a block of wood and he just kind of grooved out little steps. And it was good too because it was easy to measure. Okay, well, yesterday they made it to the 5th step and today they made it to the 7th step. So it also kind of gave you a real concrete way of measuring their progress, and you could tell the patient that too. Look, you made 7 steps. You only made 5 steps yesterday. So I did so much with this mirror. That's a lot better. We did eventually get a shoulder arc. We didn't have one at the time I did this. And they are good. They do crossing over the line and everything else. But this worked. It worked in a pinch. So, okay. Is it okay for OTs to work on dynamic standing balance? Yes. Absolutely. I mean, what do our patients have to do that uses standing dynamic balance? Getting clothes out of the closet, putting things in the refrigerator. It's really important if they weren't using a walker before and now they are to really concentrate on dynamic standing balance. For this, I'm going to need a volunteer. Come on down. You have one over. Okay, this is for the volunteer.
Alrighty.
And this was a real cheap way I found to work on dynamic standing balance. I'm not going to stand by her at this point because I'm assuming that she's
Yeah.
pretty steady on her feet. So please tell me if I'm wrong. So this is again, I bought a bag of those balloons for $1 at the dollar store. Again, petty cash. Someone brought the badminton rackets from home, so we could do a lot of dynamic standing balance really cheap. Yeah. Okay. Now that's easy. So can we make it a little harder?
Yeah.
And someone's going to need to come put a gait belt on this.
Both feet or 1 feet?
One feet?
Okay, 1 feet. I'm not an English major, okay? I got English.
Is that a little more challenging?
A little bit.
1 feet.
No, the only thing you have to worry about as a therapist is getting whacked with the racket, which I'm not.
Yeah. I think you should use your non-dominant hand.
So I was hoping I'd keep y'all awake. It's a Friday, I'm sure you guys are tired.
I'm having fun.
All right, that's good. I think she deserves more than 1 treat.
Yeah.
And I want you to sit in the middle like you've already gotten to a sitting position. And are your feet touching?
No.
Yeah. Same way your feet are touching. Huh? Okay, so they make these things called transfer poles. They're really cool. And the reason I learned about them was I watched the CNA walk over and just go, here's your letter. It's relatively rare. I've only had 2 patients with it in 36 years. It's rheumatic in nature, which means it's autoimmune. And they have severe pain in what they call the spondylus of the spine. It can go to other joints, but it primarily begins in the area of the spine. They have a lot of back pain, and eventually the spine fuses. Most of the times it fuses within kyphosis, but I had a man in his 70s where it fused in extension. He had no mobility in his trunk, none. It was like a 2x4 was tied to his back. He could not come forward, his wife said, his 70-something-year-old wife was taking care of him, that if I could get him to where he could get out of bed by himself, she could take him home. She could do everything else. She could help him get dressed. It's just she had a bad back and she could not do any lifting or pulling. So we worked on this for a very, 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 very long time. So I found out there's something called a transfer pole. It extends from the floor to the ceiling, and it attaches to the floor and the ceiling. And most people use it by their beds because with anything else, there's other ways to adjust, like taller commode chairs or lift chairs or whatever. But the bed is where they usually use it. I couldn't actually order one for where I worked because the ceilings had the things where they were the little panes that would pop up, so there was nothing to attach it to on the ceiling. And I thought, well, how am I going to know whether or not this man can do this before I tell the wife to purchase it and spend hundreds of, you have to get it professionally installed, so I wanted to make sure it worked with him before I told her to go out and spend all that money. So we practiced for a long time, and I guess you probably, you want at least a third of your leg off the thing to get the lift off. With him, I would use this. Do you want me to do it? It you're okay? Okay. Yeah, well, sometimes what I would do is I would have the front, and I would be guiding him forward, but basically, all you do is you reach up with the hands, and then I would have that under his feet, so his feet wouldn't slide. I would have the gait belt, and then I would just kind of prompt him to go forward, and you just basically pull yourself to a standing position. And it worked really well for him, and he got to go home, and he actually lived in my neighborhood. He went home. So this is, I kept one of these. In fact, later on I made two. Good job. I made two because it's also a good thing for strokes that have no proprioception to get them to reciprocal walk. And I would have two of them, and we would do left hand. This gives them proprioception input because they're holding the pole and the pole's hitting the ground. And I had a man in his 50s, very young. He was very motivated. He was falling 5 times a day. He was so motivated. And it was kind of like, okay, guy, I applaud your motivation, but you look like you've been beat up. His walking was very awkward. And so we did this in the hallway, PT and OT together. We'd do, left hand, right foot, and then we would do left foot, right hand. And he finally got the pattern, and he ended up going home, which is quite nice. So he looked great when he left. In fact, he came back 6 months later to visit, and he was using no assistive device to walk. Oh, gosh. Okay, get up. All right, how'd she get up? Did she roll to her side? No. Right, okay. Most people, that's how they get up. We teach our patients to roll to the side for several different reasons. One is just energy conservation, or to protect something that's hurt. But it is normal. It is normal to sit up and get out of bed. I do it every morning. A lot of times when they do a distal femur fracture, they have those long leg braces that keep their leg completely in extension. They certainly don't want to roll over on that side, and even sometimes rolling that leg over the other one is painful. Some other examples. My man who had ankylosing spondylitis, he had difficulty rolling to his side. You have to have a little bit of front mobility to roll. So they make these things called bed ladders. But again, I didn't have one. And so I thought, how could I see if this person could use a bed ladder for me to recommend that the family buy it before they purchase it? So I used a sheet, and you grab it off. I stood at the end of the bed. Usually what I would do, this isn't really a hospital bed, so I can't do it with this. I would keep the rails up, and I'd put pillows between the rails and the patient in case they rolled sideways. So, see if you can pull yourself to a sitting position. What they do is they're on their toes, and well, I'll ask you in a minute why. They're on their toes, which really brings this hip up way high, so they can't clear the foot. So what they do to advance the foot is they swing it out and in, which is a horrible movement pattern because 2 years later they got terrible back pain. So why do strokes, what is causing them to be on their toes? Do you know what reflex that is?
Spasticity.
It's spasticity, but there's have y'all done the primitive reflexes on infants? Okay, when you stand an infant up in your lap and it's on your toes, and everybody's going, look, it's standing, and it's not standing. It's a positive supporting reaction. So adults, when they have brain injury, then you'll see some of those. So remember, whether you do peds or adults, you'll need to know what those reflexes are because you'll see them in brain injured individuals. I don't think we ever really get rid of them, we just override them, and then when there's a brain injury, they tend to pop out. So they taught the OTs to analyze gait and the PTs to do ADL, so it's really amazing. But AFOs are good for breaking up that positive supporting reaction because they put the foot in more of a what they call subtalar neutral position, but they're plantar flexing and inverting. So you have to wrap them in dorsiflexion and eversion, and it breaks up that supporting reaction. And sometimes if you can get them through that, where they work through that reflex, they'll never need an AFO. let me tell you that, being NDT certified, the dynamic AFOs are much better than the ones, the store-bought, off-the-shelf ones that are just fixed. They make ones that are dynamic, that have to be custom-made, that have a dynamic component to the ankle. It's not good to immobilize any of our body parts, whether we've had stroke or not. It's just not good for the joint. Since I want the force to go up and out, I start here. And as I'm going up and out, I pull harder. And then as I come on this side, I'm lighter. And they can usually still have their shoe on. We just want to make sure that it's takes some prep time, but it's worth it because it will sure break that up. Don't ever buy this kind. Okay, so I'm just going to kind of end there. Okay, so try to point your toes, and then relax. Do you feel like it's kind of pulling you back up and out? So this was $8, you know, and an off-the-shelf AFO is $120, and the custom ones could probably be as much as $800. I lost my central vision at 11, and I was told I would never lose anything else. They diagnosed me with Stargardt's. I raised 3 kids, 5 grandkids. I had a dirt bike, I had a bicycle. I went water skiing, snow skiing. I had a very active life until about 50, and I started losing my peripheral vision. Of course, then I went to places all over the country to find out what was going on. I just recently got diagnosed with retinitis pigmentosa. So I was misdiagnosed for 30 years. So I'm losing the superior peripheral. I still have inferior peripheral. So, you know, I compensate by looking up, you know, raising my head, lots of scanning, all the things you teach your patients to do. Lots of scanning. I do use a mobility cane, especially if I'm in unfamiliar surroundings. Obviously, I don't use it at my house or places I'm familiar with, but it comes in handy. It catches things I don't. The whole reason I went into the OTD program was to teach. So this is what I want to do. I loved teaching as a CI, so I thought maybe I would enjoy this just as much. Even though I'm technically old enough to retire, I don't have enough money to retire. And so I really think I would enjoy doing this, and you guys made it great. Y'all made it easy, let me tell you. Y'all were awesome. But that's what we're there for. We're there for the patients, right?
Well, and one thing I like that Margaret mentioned, they use that quilting club to make those walker bags, and I've had things like that too. And also the other thing are like high school shop classes will make things. I've had them make things for me too, like tea stools for little kids and finger ladders and things like that. So you just find people who need projects. Thank you so much, Marina.